I've got no relevant disclosure, so I didn't include this slide. So we published 2 different manuscripts on this in standard fashion, an animal paper followed by the first-in-human report, and I'll use that as the basis for the talk. The need, everybody knows, coronary obstruction is devastating. There are some prevention techniques which have been discussed in detail, but sometimes patients aren't eligible for what we currently have available. So the vector concept, like every good technique, we find a patient that needs something and we come up with an idea. And in Vector's case, the team felt we should just relocate the coronary ostium. That would be the easiest way to treat someone. So we worked on it in animals to elevate the coronary ostium above the level of the obstruction risk and use a stent graft to connect that to a distal anastomosis in the vessel of relevance, which in this case was the left main. The patient that we had was one of Adam Greenbaum's patients at Emory, 67-year-old, severe degeneration of a 25 magna E's, lots of comorbidities, including a right leg amputation, which is what he was having done when he was discovered to have severe stenosis in the first place. But when he came back for the procedure, he had critical limb in the left leg. So his STS was phenomenally high. Just for his CT, this is just an example of the confluent calcification on all 3 leaflets. Looking at the left in particular, as I sweep in the long axis, you can see that there's no calcium-free window for a traversal for basilica, for unicorn, or anything. And in the short axis, in the axial view, you can see that that confluent calcium just extends right to the tip on all 3 leaflets. Also interesting, if you look at the eccentricity of where the left main comes off right beside the left-right post. Even if we were able to do a leaflet modification, it's not ideally placed. I'll just skip type VTC. So the vector procedure itself, we established the patient on ECMO electively because we weren't quite sure how it was all going to go, so that might have been the best way to start. And then we were going to create an AV rail from the coronary to the right ventricle and work retrograde up that to establish a distal anastomosis in the coronary artery. Use electrosurgery to create the proximal anastomosis in the aorta, connect the two, and deliver a stent graft. The AV rail is really the one of the key innovations in this, and I'm sure Robert will mention the inspiration afterwards, so I won't. But we get into a septal vessel. In here, it's the right coronary in the cartoon, but for the patient, it was the left. Into a septal and navigate from the septal vessel into the right ventricle, where we snare the wire, externalize it from the right femoral vein, and that's now our primary route to work retrograde up the coronary. This is what it looked like in our patient. So in 2 views, you can see a guide wire coming from left main through the septal vessel, and the equipment that's positioned in the right ventricle was where the snare was positioned. And now we have free access to work retrograde up the septum and back into the left main. So the distal and proximal anastomoses, these are obviously the most important part to get right. The puncture site in the left main needs to be far enough away from the circumflex, for example, that when we deliver the stent graft, we don't close off one of the coronaries. And the proximal anastomosis has to be at a level above which the obstruction isn't going to occur when we do all of this work. So I'll talk through each in turn in the next few slides. But the next key innovation for the distal anastomosis is something we call the stent and stingray technique. So using some of the learning from CTO world, we get the stingray balloon catheter retrograde up the septum and back to the left main, and then stent that to the roof of the left main with, in this case, a 7x15 stent, because the left main was gigantic. You can see that the 2 dots of the stingray just being elevated to the roof of the left main as the stent is deployed. That now gives us established backup force for the next step to get a wire out of there, and it also maintains coronary perfusion as opposed to something like a balloon-assisted exit, which I did try and failed. This is the guide wire being pushed through the superior port of the stingray. So obviously in CTO world, we want to go back to the lumen. We're going the opposite direction. So that mechanically, the guide wire is just pushed out of the coronary vessel and into the pericardium. And you can see from the angiogram that we are where we intended to be. So the next is the proximal anastomosis. That's much easier. So we just use electrosurgery, burn out of the aorta into the pericardium, and what could go wrong? In the left side, you can see that we're lining it up at the level that we perceive the obstruction risk will be 0. And then on the right side, we're just burning standard electrosurgical technique through the aortic wall. The last step to create the rail through which we're going to deliver the stent graft is to just make the connection. So we snare the retrograde wire with the anterograde equipment that came out of the aortic root. And that now establishes a rail from aorta. You can see on the right-hand side, from aorta to left main, and that's what we're going to use to deliver the stent graft. In this case, we used a 26 millimeter long papyrus. It was the biggest you can get is a 5 by 26, so there's some flow in that 7 millimeter left main after we deliver the stent. But you can see that it extends from aortic exit, proximal anastomosis, to the distal anastomosis. And the stent that was pre-positioned for our stent and stingray technique just gets crushed out of the way. And that section between left main ostium and the stent graft is going to be redundant afterwards because there's going to be occlusion. So this is now, after stent delivery, an angiogram down the newly positioned stent graft. So you can see brisk TIMI3 flow into all of the left-sided vessels through that stent graft. It extends from the aorta, and there's no reflux or leak around the stent. This is then the Tavr deployment afterwards, and I've got two very ugly-looking triangles on the screen. If you look, the white triangle is pointing to the left main stent that we positioned for our stent and stingray. And you can see that it's protruding slightly from the left main ostium, but gets crushed by the leaflet of the surgical valve replacement as the Tavr is put in. So without some other protection, it's kind of like 100% confirmation that this would have occluded. On the right, the aortogram, you can see the lucent line. The leaflet's just jammed up here against the stent, but there is a good brisk flow down the coronary. I'm going to go back one just to show you the CT, if it'll let me, and it won't, and we're gone. So anyway, vector, it worked. You can reopen it? Okay. Okay. Yeah, we're not exactly pretty. Okay. So this is just the CT, day after. You can see the stent graft going from aorta into left main. The left main stent crushed against the S3 inside the surgical valve frame.